You are all welcome to this morning's worship. We're far behind time, so we'll take an opening prayer and then introduce ourselves. Can we have somebody praying for us? Somebody led by the Spirit. Dr. James Bronco.
Please let's close our eyes for a word of prayer. Daddy, we thank you so much for this morning. We pray that, Father, as we meet to discuss today, you be in our midst. And Father, help us to learn and share and also make our practice here even better. This and many other blessings we ask in Jesus' name. Amen.
Thank you very much, Dr. James. So we'd like to introduce ourselves. I made an observation. I thought I was the only one who made that observation. But American Director also noticed that the DTC members were here. Some people were here. Others were there. So we'd like to know ourselves. We'd like to know each other, your name, where you're coming from, if possible, your position. If you're a visitor, if you're a staff member. So we'll start from the high table.
Good morning to us all.
Good morning.
My name is Mary Eke. I'm a pharmacist and I'm coming from Project Hope. I'm the Senior Technical Advisor on Essential Drugs, Diagnostic Devices, Vaccines, and Microbial Resistance. Thanks for coming.
Hello everyone, good morning. My name is Joanna Adide. I work at Ghana Health Service, ICD, QA department. I'm a DCN.
Before we continue, I'd like to let us all into a very big secret. Mary doesn't want me to say about it. One of her legs is in Summer General Hospital.
Oh, wow.
That is messing up the general office.
Okay.
Thank you very much. I'm William Adolon. I'm from ICT. I'm the head of laboratory, Ghana Health Service, clinical lab.
My name is Laura. My name is Laura Solo. I work with the Summer General Hospital Laboratory and currently the head of laboratory.
Hello everyone, my name is Dr. Derek Almo. I'm with the ONG department of Summer General Hospital.
Medical Director at Summer General Hospital. Thank you.
Good morning, Rose Dennis, Pediatric Nurse Specialist, Pediatric Emergency Unit. Thank you.
Good morning. My name is Kofi Bani, Laboratory Department, Summer General Hospital.
Good morning. My name is Heidi Nomisi, Pharmacy Department.
Also from the pharmacy department.
Dear Official Walker, Training Coordinator.
Good morning, everyone. My name is Jennifer Sabo. I'm a pharmacist with the ONG department.
Dr. Jennifer Sabo, another the doctor for me.
I go by the name Awadu Lesaju, with Ghana Health Service, ODPS.
Alright, good morning. I'm also Dr. Emmanuel Owusu with the Pharmaceutical Services, Ghana Health Service Headquarters.
Good morning. I'm Edna with Pharmacy Directorate at Headquarters.
Thank you very much. And my name is Vivian Nama. I'm a pharmacy at General Hospital. So now that we got to know each other, we'd like to invite, last but not the least, the head of finance. He has all the money. Yes. All the money. So before he sits down, let's introduce.
My name is Dtc.
Thank you very much, Mr. Steve. So I'd like to hand over to our medical director to give us a welcome address and opening remarks.
Thank you very much, everyone, and good morning. It's she's not here, but Madam Chair and dignitaries from the Ghana Health Service, we are grateful as a facility that you are here to engage us on this workshop. We want to say thank you for thinking about us. I want to thank you for the itinerary as I've gone through it. It's very insightful, and I think that it will bring a lot out of us. I also realize that you're trying to shape our thinking in terms of the work from various aspects. The fact that the laboratory staff are here and their head are here, those in the pharmaceutical industries and those of us doctors who use these other arms in management are here. We hope that we're going to have a fruitful discussion over these 2 days and pray that whatever we get out of here, we'll be able to develop SOPs out of them and have guidelines by which we're going to do the work. So on behalf of all management, I want to say thank you for bringing the weather to be here, and also all presentations that are going to be put up will be a learning experience for us. We in International also are grateful. Thank you.
Thank you very much, Director. So we'd like to invite Auntie Edna to take us through the objectives of the workshop.
Good morning again. It's a pleasure to be here this morning for this important training on strengthening drugs and therapeutics committee and zooming in to strengthen antimicrobial stewardship programs within Ghana Health Service. We want to sincerely appreciate IHP, which is Integrated Health Partnership, specifically Project Hope. It's unfortunate Mary has stepped out. We want to express our gratitude to them for sponsoring this program. Without them, this wouldn't have happened. So we know that effective DTC is not merely a committee that meets periodically and collects PDMs. It is a governance engine to guide rational medicine use, promote evidence-based prescribing, supports antimicrobial stewardship, oversee formulary management, and overall safeguard the sustainability of our drug supply chain. Today's workshop is more than just a training program. It represents an important milestone in our journey to strengthen medicine governance, improve patient safety, and protect effectiveness of saving antimicrobials for future generations. Antimicrobial resistance is no longer a future threat. We all know that it's happening right now. Around the world, infectious diseases have become more difficult to treat and have developed resistance to the drugs upon which modern healthcare depends. Within the Ghana Health Service, we have observed another important reality. Our investment in medicine continues to grow, and anti-infectives account for the largest share of pharmaceutical expenditure across the facilities. While this demonstrates our commitment to patient care, it also reminds us of our responsibility to ensure that every antimicrobial prescribed is necessary, is appropriate, and safe for use, as well as cost-effective. That is why strengthening drugs and therapeutics committees has become a strategic priority. Our vision, therefore, is straightforward but ambitious. We want every facility to establish a functional, multidisciplinary DTC that serves as the institutional home for antimicrobial stewardship. We want stewardship to become part of routine clinical governance, not just a project, not an event, but a culture embedded in every practice. So in this training, we will explore practical approaches to antimicrobial stewardship, governance, surveillance, infection and prevention control, diagnostic stewardship, and then the responsible use of medicines. More importantly, each facility will be required to develop systems that will continue long after this training. So I encourage every participant to engage actively, share experiences openly, challenge existing practices constructively, and return to our facility level as champions of change. So to all of us here, this workshop is an investment in our leadership towards antimicrobial resistance. We are counting on each of you to translate the knowledge gained here to measurable improvements within our respective units. So together, we can strengthen medicine governance. Together, we can prevent and preserve our antimicrobials. And together, we can build a safer, stronger Ghana. Thank you. Forgive me, I forgot to bring you greetings from the Director General of the Ghana Health Service. We are here on his behalf. And once again, also, I bring you greetings from the Director of Pharmaceutical Services. This has been his baby. He's the Chief Technical Director for this antimicrobial, I don't want to call it project because it's a continuous thing. It's not going to be a project that will end. But he's been championing this, and he very much regrets his inability to be here. But we are here to do justice to what he has sent us to do. So greetings from Director Pharmaceutical Services, Dr. Dominic Kosa-Otri. Okay, a little quiz. We are all senior managers, but a little quiz. So I'll go back. Please, who can remind us of our vision as Ghana Health Service? Before going for interviews over and over again, now we are senior managers. What is the vision of Ghana Health Service? When we come to work every day, what is our vision? What do we hope to achieve? What are we working towards? This one I will require an answer.
It's there. It's there. So it's like we are copying the exams. It's there. Oh, maybe I shouldn't have told this there.
Yes. Director has reminded us that it's there. I was hoping that you've not seen it. But I just want to remind us of something. It has been changed slightly.
Yes.
Changed slightly. What is there? Who can tell me the old one? I'm hoping you didn't have good eyes to copy. So from memory, who can tell me the old vision? You forget about the mission, the vision, just the vision. It used to be simple. Hey, me, I know, pharmacist here, I know your name, so I'll put you on this one.
Oh, no, don't.
What was our old one? A healthy population with universal access to quality health services. That was very simple. But it has been modified slightly. Now it reads all communities having access to timely, quality, and comprehensive health care. Please, I'm very happy that you have it there. If we don't have it in our offices, let's put it there. So that as we see it every day, it gets in our heads. So that when we are asked outside the hospital, Ghana Health Service, what's your vision at all? We wouldn't be like, you will come and tell you later. We will be able to answer right there and then. Okay, so why strengthen DTC? Why are we here to strengthen DTC? Every medicine decision in the facility ultimately affects four things. We know health care is incomplete without medicines. After going to see the physician, after the right diagnosis has been made with the support of laboratory and everything, we do not let our patients go home empty-handed. For about 90 to 95% of healthcare, medicines are involved. It's not psychotherapy. I'm sure if we didn't have pharmacy units here and patients were just to come here for diagnosis and then go to the community for their medicines, a lot of patients wouldn't come here at all. Why go and why bother to go and know what is wrong with me when they cannot help me and they give me what will cure me or treat me? So medicines are heavily involved in our healthcare. And for every medicine decision, like we said, it affects 4 key things. Patient safety. Whether that medicine is right for that patient, whether it is in the right dose, whether it is even the right drug for that condition. Based on that, it affects our quality of care. Because the medicines we are giving, if there's no evidence to back why we are giving and how effective it's going to be, then we cannot assure our patients of any quality care. They come, they take medicines that don't cure them, then we've not done anything. We've not given them the quality care. We've given them medicines, but we have wasted their time, we have wasted our own time and our resources. Today's one, we are focusing on antimicrobial resistance. Like I said, it's not a future threat. It is happening right now. And as we go on, we will see the consequence of it. The threats are dire. The consequences are dire. So it's about time that we face it head on and we tackle it. Otherwise, years to come, a lot of us will die unnecessary death. But at the end of the day, all this is being affected by cost because we are going to use money to buy it. So DTC is here as the governing body responsible for ensuring that medicines are used safely, effectively, and responsibly throughout the hospital. That is the goal of DTC. So the Drugs and Therapeutics Committee is a multidisciplinary committee that provides leadership in 6 key areas. Number 1 being rational use of medicines, medicine policy, formulary management, antimicrobial stewardship, medication safety, and continuous improvement. So the goal of this trainings that we are doing is to make sure that every Ghana Health Service facility has a functional DTC. And this DTC has clear medicine policies. I know pharmacy head will make a presentation, so we will get to know whether you have these in place to make you functional. We have standard treatment guidelines. And beyond that, we have gone to even develop SOPs for the different units. We should have a functional AMS program, AMS being antimicrobial stewardship, a functional antimicrobial stewardship program, and that is why we are specifically here to strengthen. And every decision is being backed by data. DTC should be backed by data-driven decisions. And ultimately, at the end of everything, we are looking for the safety of our patients. So, safe patient care. What are the expected deliverables or outcomes? If we do not have them, we should establish a DTC that will strengthen medicine governance. This DTC should have approved terms of reference, annual work plan, documented minutes to make it functional, quarterly meetings, and management reports. I hope we have all this in place. If not, we are reminding you that that is the purpose of the first objective, which is strengthening medicine governance. In terms of governance, there are 6 deliverables also over there. And in terms of promoting rational use of medicines, we have 4 deliverables. We have to have in place standard treatment guidelines at every consulting room for every unit. We have to have frequent and regular prescription audits. We hope that is going on. Drug use evaluations. If you don't know how to conduct that, then we seek support for that. We have prescribing feedback reports. Do we communicate frequently with the prescriber? Do we give them the bulletins? And do we get their feedback in terms of prescribing? The other objective is to strengthen hospital formulary. We hope that the facility has its own formulary aside the essential medicine list. You have formulary reviews. We hope that that is going on. If not, we are reminding you. We have a formulary manual and non-formulary request process. If a prescriber wants to prescribe something outside the facility formulary, what are the processes to go through? Number 4 is to lead antimicrobial stewardship. That's the main purpose we are here. Do we have a functional AMS team? Do we conduct point prevalence survey, which is PPS? Do we have antimicrobial guidelines or antibiotic guidelines, AMS action plan, antimicrobial consumption reports, and antimicrobial review meetings? These are things to look at under the antimicrobial stewardship committee. So if the committee exists, these are the deliverables. These are the things that when we come and we want to see if we have a functional AMS, these things should be there. 5 is to improve medication safety. And that one, in collaboration with QI or QA, we will be doing that. I wouldn't bore you. Do we have ADR reports, medication safety reviews, patient safety recommendations, medication error reporting, and risk reduction plans? All these should be in place. And lastly, to monitor drug use. In monitoring our drug use, these are the things that should be conducted, and there should be reports for that. Medicine utilization reports to be conducted, and we have the reports ready. Cost analysis, prescription indication, and all these things. And at the end of the day, we will not be able to fight the antimicrobial resistance issue without education. So we should build capacity. Capacity within the technical people here, lab and prescribers and nursing and pharmacy and all. But going beyond that, we get to know that antimicrobial resistance is not just an issue for the clinician. It's all of us our issue. It goes beyond health. It goes to agri, the environment. So everybody needs an education. Even our cleaners. How well have we educated them about infection spread? Do they clean really how? So we realize that education is needed for everybody, aside your core technical things to look out for. We should all be trained on how to prevent infection, and when unfortunately it happens, the right things to do. So these are the deliverables for a functional DTC. Annually, you should have these reports ready. If all these are in place, I've already spoken about it, so I won't go back. Then we can say that DTCs are functional. And when they are functional, then we know that we are fighting antimicrobial resistance, because our AMS teams will be in place. So at the end of all that I've said, we want to see better governance in terms of DTC, better prescribing, which will lead to reduced medicine waste, reduced AMR, improved patient safety, lower cost, and better health outcomes. So these are the objectives of the training, that we will strengthen DTC, say that at the end of the day, when we leave here, these things will continue, and these will be there to prove that, yes, we have functional DTC. Because at the end mindful of all that we are doing. Thank you very much.
I think that we should keep it to better. Let's as the General Hospital, DTC also gets ready to present activities. A brief overview of DTC activities in the General Hospital, and that will be presented by Dr. Pham Janice Isendo. Let's clap for her. Let's go for it so that she will deliver very well.
Good morning once again. This is a brief overview of what we do as a committee here at the General Hospital. This is going to be just an agenda or the outline of the presentation. So by way of information, the DTC committee is established under the Ghana Health Services standards and also guided by operations under the WHO, and we are mandated by the FDA and also regulations from the pharmacy policy. And our core purpose is to ensure that our patients receive rational, safe, cost-effective use of medicines in all our departments. And our scope covers all areas in the facility, inpatients, outpatients, and all the specialized areas in the hospital. Our committee is multidisciplinary. There's an 11-member committee. We have the chair being the head of pharmacy. We have 2 clinical pharmacists. We have 2 physician specialists representing all the doctors that we have in the facility. We also have 2 nursing staff, 1 specialist nurse and also a public health nurse. We have the head of lab also represented. We have a rep from administration, procurement, and also our QI focal person is also part of DTC. In summary, these are our activities. 1, we manage the formulary of the hospital. For our formulary as an institution, we review it once in every 2 years. We've done that for this year, which is ready to be given us. Also, as part of the formulary management, we deal with additions and deletions. There is a guide for that in the formulary, which is based on evidence. So if we have to take a medicine out of this, is guided by principle, which the formulary management comes up with. We also, as part of formulary management, take care of therapeutic substitution. We notice that we want the medicines that we give our patients to be cost effective. For example, for medications like Nexium, for instance, which is a bit on the high, we try to substitute it, not also going down effectiveness. So let's say we'll do more of omeprazole than Nexium, so that the patient too, it can be a bit easier on their pockets. The formulary also, as part of the management, also takes care of stock out management. We have protocols to manage drug unavailability, including approved substitutes, and also communicate to prescribers when that is done. Secondly, we also manage treatment guidelines and also drug policy. So far, we have done audits in management in pneumonia as part of the drug policy and treatment guidelines. We did that last year. So we came up with a guide. We audited what we do here as a facility in managing pneumonia. We reviewed the management and also for surgical prophylaxis for common procedures at the ONG department. We have a guide here for the facility as well. We also track the WHO core drug indicators here, which includes what we know already, the average number of drugs per prescription, percentage prescriptions to 1,000 injections. We also manage non-formulary requests. For example, we have a medication we call Citam, which is used for improved cognitive function. It is not on the formulary, but every now and then, if we have medications as such, the committee meets a review, and based on guidelines, we justify the inclusion in the formulary. The DTC also manages adverse drug risk. We monitor it. We have 2 institutional contact persons that coordinate activities of pharmacovigilance in the facility. They do that passively and actively. Actively because they are going around asking for ADLs, and also passively we get requests from the various wards, from the various consulting rooms. And we also have designated ADL reporting forms available. We noticed that we are not getting reports from the wards and from the consulting rooms. So the committee came up with a simplified form so that reporting will be easier, and we noticed that has improved the number of reports that we send to FDE. The ADR committee also analyzed the ADR that we received. We also classify the severity and also send reports to the FDA for notifications. And the feedback that we get from FDA is also given to prescribers and all that are involved. As DTC, we also are involved in rational use of medicines management in order to improve patient outcomes. We also work on improved prescription patterns. We monitor prescription patterns in the department. We do monitoring monthly, and as and when they come to the pharmacy, we conduct prescription audits to identify irrational use and address them as well. We also address issues of polypharmacy and also by use of antibiotics. And we ensure that the patients receive education after that. Pharmacists provide adequate information to patients on how to take the medicines and how long. We support adherence, especially for long-term conditions such as hypertension, diabetes, HIV. We also track indicators, like I mentioned earlier, as part of rational use of medicines. Also, as a committee, we manage or we evaluate medicine use in the facility. I've mentioned some already. Currently, we are undertaking a hypertension pharmacotherapy audit in the hospital to see whether we are complying with guidelines or not. And we do this through either prospective studies or retrospective studies. Education and training. As a committee, we also educate and update our staff on our findings. We have drug bulletins that we send to all the consulting rooms and the wards to update the hospital on what we have as a facility. We also update prescribers and staff at departmental meetings for our findings from these audits. And also, every now and then, we also have new staff joining the facility. So at these orientations, we update or also we inform the new staff on what we do as a committee. And also, when there is any alert from FDA from our findings, we make sure that we are sending them around as well. Antimicrobial stewardship, I think that we've made a lot of strides with AMS. We established an AMS committee here in 2023. And last year, we reconstituted the the committee. It is a 7-member committee. And so far, we've come up with guidelines. I mentioned that already, pneumonia and also SAP. We've also conducted point prevalence surveys. And we noticed that with the education we carried out after our first PPS, we saw that for the prescription for access group of antibiotics, we saw an increase. It's moved from 56 to 59%, which I think is a good thing. And we've seen that prescription generally for antibiotics, when we do our analysis over the past 6 months, has decreased drastically. Last 2 quarters, we reported less than 20% for the very first time as a facility. We've also observed World Antimicrobial Resistance Awareness Week over the period. For the past 3 years, we have consistently engaged patients, we have engaged staff, we have had healthy interdepartmental competitions on AMS just to create awareness. And we've also pulled sister facilities around along. We've had about 4 facilities coming here to learn from us. We've also visited them to help them put up committees in their facilities as well. I can remember Ashaman, I think Mani here, Mamobi, if I'm not mistaken. And currently at that we are helping them set up an AMS committee. And we are also collaborating with these facilities so that it will not just determine general hospitals win, but in our fight in AMS, AMR, it will be the win of Greater Accra and Ghana at large. We also engage in public education through radio, through the schools, through the markets in AMS. We meet as a committee, we meet every other month. So we have 6 meetings in a year. We have 6 meetings in a year. And we have subcommittees. We have the formulary committee, we have AMS committee, we have a committee for pharmacovigilance. And we want to also, going forward, come up with a research committee that we are working at. And for our reporting, we report as and when we have the meeting. And the minutes are sent to the hospital management and also to the regional directorates of GHS after every meeting. Our achievements, I would say that our formulary has been updated and is ready. We have our bulletins also ready also from the formulary. We have our AMS committee formed with champions on the ward. We also have noticed that our ADR reporting rate has increased over time because of the interventions that we put in. For pharmacovigilance, we have 2 trainings every year just to sensibilize ourselves and everybody. We have also had improved antibiotic use indicator. That's an achievement. We've also improved the access antibiotic prescriptions. And also we have observed wow over the past years. And also our key challenges, I would say, will be some of the stockouts that we receive due to supply chain disruption. Sometimes we really can't do anything about it, but that is one of our challenges. And for AMS activities, looking at the numbers, there's limited dedicated pharmacist physician time for stewardship. At the moment, we have our AMS rounds weekly, but we notice that sometimes we get busy because we have other duties, and we only have it at the medical wards. We want to take it up to the surgical ward, but the numbers are not helping. So that is a bit of a challenge that we are hoping that we increase the numbers and then go on to the surgical wards as well. Moving forward, we still want to strengthen pharmacovigilance activities and also strengthen AMS activities as a facility. We know we have a long way to go. Thankfully, we don't have any record for reserve antibiotics, which is not bad at all. Our access has shot up, but we still feel that stewardship is ongoing every day. So we still want to strengthen activities for AMS and also pharmacovigilance. So thank you so much. This is just a brief overview of what we do. Thank you.
So dream big, start small, move fast. gradually we are making successes. We're proud of that. A round of applause for all of us. As we encourage ourselves to do more. We'll look at antimicrobial resistance being a silent pandemic, and we'll have Dr. Emmanuel Owusu to take us through. Okay, so before we do that, let's get ready. I told you that we'll have a pre-test, so let's get ready. We'll have a pre-test lasting for just about 5 to 10 minutes. Right, so the QR code is there. Can we start?
Yes.
We should start.
Yes, please.
20 minutes.
Oh, no. 10.
10 minutes.
10 or less.
10 minutes. 9:47, 9:47, and then we'll be done. Good luck to all of us.
Paper.
10 minutes up. Please, are we done? We're done, actually. Should we go? We should go on to the program.
Yes.
Or we should give ourselves about a minute more. The results I've seen, the results that are trickling are very impressive. So I think that we should just press the send button. Push it. Alright, so quickly we'll move on to look at antimicrobial resistance, the silent pandemic. And this presentation will be done by Dr. Mawina, coming all the way from GHS headquarters. Please let's give it up for him.
Hello, good morning. My name is always Mario. And today we'll do, can anyone hear me? Okay. So going through the earlier presentations, I realized that my wife will be very busy constantly. Because I mean, everybody, or most people here know about AMR because there's too much activities. Also, I saw a few papers on people's, on various points of stewardship. There was an assessment of the core elements in AMS. There was also some KAP on AMS, so we'll run through very easily. The definition will look at history, burden, and then the action plan. So usually I want to appeal to your conscience. Many things that we're not responsible for, but in an issue like AMR, all of us are responsible. All of us are involved somewhat. So as early as 1945, I don't think any of you here was born. I was, so I'll tell you what's happened that time. So Alexander, who discovered penicillin, was saying as early, so 1928, penicillin was discovered, right? And then 1945, about, he says that the greatest possibility of evil in self-medication is the use of too small doses, so that instead of clearing up the infection, the microbes are educated to resist penicillin. And an organism, some people organisms are bred out, which can be passed to other individuals until they reach someone who dies to septicemia an AMR. And then he also said that thoughtless person playing with penicillin treatments is morally responsible for the death of the man who succumbs to infection. So like in a simple scenario, if I was driving fast or reckless, and then someone who was trying to dodge me, and maybe I was driving on the street and no one is crossing, and the person jumps and falls in the gutter and breaks their head and they die, I think it's them. Will I be responsible for their death? If you think about it. I mean, if I'm responsible, show my hands.
The scenario again.
If I was driving recklessly, then someone in a bid to avoid me jumps out of the road and then falls in the gutter, hits the head and dies. Am I responsible for that death? I think it's them. They should have watched where they were going up. I mean, that's a similar stuff happens with AMR, where the things that we do in our houses can affect the next person, and we'll see that going forward. So what is AMR? All of us agree that anti-infective agents are being beaten by the microbes. So parasites, bacteria, fungi, and all are able to fight the medications we use, rendering them obsolete. So before 1928, where no one except me was, people would die from a simple infection. I mean, you die from an infected cough, chest infection, skin infection, and then penicillins were discovered. So then they became what we call the miracle drug. Because I mean, people don't want to die from these simple things. Most of us can't really because we have access to medication, so we can be able to fix that simple cellulitis or whatever it is. So before that, it was saving them, but then at a point it's not doing that again. And why that happens is usually, why that happens is during the misuse of antibiotics. AMR, resistance is a natural phenomenon, it happens naturally. The moment there's use of antibiotics, we expect that AMR is okay. What I'm saying is that if we should discover a new antibiotic agent, and we call it maybe Mawina cycline, for instance, and you put it in a box, it's unlikely to have resistance, except natural resistance. Natural way, I mean, if you cultured Pseudomonas, for instance. I'm sure you have no business wanting to prescribe amoxicillin because you know it wouldn't work. That's the natural one, but then some come over time. So if you keep it in a box, for instance, there will be no resistance. So the moment it is used, mind you, the use is not just rational use of antibiotics, also irrational. I mean, not just irrational, but also rational. So you can see that, oh, maybe at prescriber level, I didn't see an infection, but if I give the medication and it is there, it will clear it. If it's not there, it won't kill the person. All we're saying is that then that becomes irrational use. Because whether or not the person completes the dose, there is use, and that can drive AMR. It's variable resistance, highly variable. That is why I find it laughable when someone tells you, oh, I had this infection, and my pharmacist in the UK said I should use this. When you said I should use this one, because I mean it's different. All of us agree how different these are. I mean that at Tema, the microbes that you play with are different from at Koforidua or in Kumasi. So if it's better for the people down here to make the decision for you, it's the reason we champion facility-specific guidelines that I'm sure you are on already. I said use is the principal driver. Now the cross-service sector. I mean, right now, today, we're worried about, let me ask the question that usually I'll ask. I want to ask, who didn't have any antibiotics yesterday? You can show by answer, you didn't have any antibiotics at all yesterday. You didn't have any antibiotics? Okay, so if I said you had, I'm sure you would argue. But you see, for the use of antibiotics in agriculture and other things, all of us have had some antibiotics, unfortunately. So everybody has like a fair dose of antibiotics because the eggs you had, they're used in poultry, they're used in cattle farming and all those things. So you see, there's high use already. That's why we should take it more personal. Now, why we see it's a silent pandemic? So unlike when COVID came was announced, all of us are aware of COVID. But it is shocking that as of now, people don't believe that an AMR problem. And I think at the pharmacy desk, we can relate a little more. Because you know, sometimes, this is our inside joke, but I'll say it anyway. Sometimes you can almost tell the age of the prescriber by the prescription. Because someone will tell you that in 1992, we were using this antibiotic, so why is it that we drink them out? I mean, so you can see that those are older guidelines that might sometimes almost be obsolete. So we want to, the reason we're here, I mean, to raise awareness and make sure these things will go as far. Sorry. So no single outbreak like COVID or Ebola where it's easy for people to relate. I remember about before COVID came, we were doing some of these things on AMS, and then people could hardly relate. Why are we washing our hands? Why must we use sanitizer and all those things? But when COVID came, it became easy because now everybody washed their hands. So even kids who are washing their hands. So AMR will not give us that announcement and say that I'm coming to stress you tomorrow. COVID would, Ebola would, other ones, but this wouldn't. Why would you take it rather seriously? And I spoke about, and it's borderless. I mean, because we travel, because we work, there's trade, we're able to share some of these problems very easily, making it difficult to care or to hold. So the history behind, I spoke about the incidence of the discovery of penicillin in 1928, and over the period, very early, resistance began to occur, which I know most of us are comfortable with already. And something had to be done, over the period. The very important factor in this AMR thing is because of the lack of new antibiotics. So over 40 years now, there's been no new class of antibiotics. The pharmacists can read it. The easiest we can do is to change certain molecules. So they will carry one OH group on carbon 14. We're going to put it on carbon 22 in the bed to surprise the microbes. So that's because there's no new one coming. I don't know the reason. I don't know that it's focused on weight loss medication that is maybe more profitable now. Or when I say weight loss, the men are happy because they think it's a woman problem. But there's also certain answers that there are lots on the market, so I mean it's for all of us. I'm not saying that the focus has changed, but when you look at drug discovery and then how much goes into drug discovery, you know, what 10 years of clinical trials, over $1 billion of money to be used in clinical trials, and there's post-market surveillance. I mean, it's a cumbersome process for one molecule. And I think most people do not appreciate that one molecule enough. I mean, they think because they can buy it. Let's put ourselves in the shoes of a farmer. If, like a thalidomide story for instance, if you use 10 years of your life to discover and $10 billion is one medication and then we'll discontinue it after. I mean, there are so many risks. I'm not justifying the reason for the lack of classes, but I'm saying that there are no new ones. And you see, antibiotics are important in every aspect of medicine, in surgery, and in curation, in preventive, so we use them everywhere. So if we don't have any new ones, and then the ones we have are becoming obsolete, then the future of medicine is in trouble. And it affects all of us. An example I'll give a story, it's like I can say stories, and because you know what AMR is already, so I should just say stories. So at a facility some time ago, one of the staff, she was admin, yes, she was an administrator at the time. And then I'm saying that because you appreciate that it's not just because the person was in clinical work, so they are more prone to AMR. So I'm saying that everybody in the space. So she had a baby, and baby was premature, baby went to leave. So the first time I heard of the story was when the cultural results came to my desk. You know, pharmacy, this is the cultural results. Every single antibiotic we could think of was resistant. Every single antibiotic. I think finally it was linezolid we had to employ. And then we had to bring that, I think, from Kumasi also to use for the child. You see, that baby had never been exposed to the environment, but started life with an AMR, with a very difficult one. So I mean, and the person was in the hospital. The problem of AMR is bigger in hospital than in the community. Most people assume that, oh, they are using it at a drugstore. They are using it in the, no, it isn't what you think. It's a myth. The problem is bigger at the hospital. I mean, we are exposed to nosocomial disease, I mean, we pick from hospital floors, because everybody who is sick comes to us. The reason we should take it very personal, because then we can be the biggest victims of AMR. On still the history, let me. So I'm sure you can see the slides from, I don't know why, I can see, I don't know why you can't see. So you shut your eyes. When you look on the right, you're supposed to be, and it's my good, you help me, I'll just draw a picture and then you appreciate it. Then over here is AMR, right? Discovery of antibiotics and then AMR. You see, there's a lot of activity in the beginning. 1928, medicine discovery, sulfonamides and all those ones. But very early, there's emergence of AMRs, the resistance. Now when it ends, activity on the right ends for here in the 1980s when there was no new class. So like I said, what they can do is they do combinations. I mean, amyl plus clav, amyl plus fluclox, piperacillin plus sulbactam or azobactam. That's kind of thing to surprise us. So you see, but the AMR still continues. So it means that we're having less medications to fight new AMRs, or whatever we have left is not becoming resistant. So we want to be serious about the whole thing. Why do we care about AMR? Because of mortality and morbidities. So someone comes to the hospital with DKA, for instance, and then because it's bad, and the person stays for some time, they get aspiration pneumonia. And that's the fault, that's our fault actually. We're responsible for those ones. Because they are hospital-acquired infections. Whether be it intervention related, you pass a cannula, you stay in the veins for too long, there's an infection, that's intervention related. To the point someone comes with something simple and goes something bigger. The idea to come into us is to alleviate the problem. But if care is not taken inside, there becomes, we can worsen the things. I spoke about less new antibiotics. It means there are fewer options. So if the old ones are not working, then we're in trouble. guidelines across countries or facilities. I remember when we were first designing our guidelines, facility specific, we used cellular design from the lab. And then the lab was seeing that things like plain amoxicillin was still very active against most of our microbes. But there's a general perception that, amoxicillin plain doesn't work, so let's use amoxicillin. And it is worrying that we see, still at retail level, prescriptions for quite simple infection and employing levofloxacin for those infections. I mean, the newer generation coronavirus want to treat them for drug-resistant TB. I mean, we don't want to expose them, but if we're beginning to use simple things, moxifloxacin, because there's a perception that hits hard at the beginning and then solve the problem. I mean, quicker, but that doesn't encourage the AMS activities. The last resort drugs usually have more side effects. You can compare for those who have had Cipro and levofloxacin. Even the Cipro is a problem. Now to have to add the levofloxacin. I mean, more side effects, more restlessness, more feeling sicker than before. Some of the infections are untreatable. The point is having the antibiotics on the shelf alone is not absolute. But what about what you have not working? If it's resistant to ketrazone, I don't know how much ketrazone. If the idea is to increase the dose, it might not do so much because of resistance. So then we have some untreatable infections. They are more expensive. At pharmacy level, they can appreciate it. How much is ciprofloxacin as compared to levofloxacin? So the level is more expensive. That's the newer generation chronology. Transmission to others, and then overuse of the broad spectrum is a problem. We want to encourage targeted treatments. So, what is this? Then the problem in Africa, we don't even report as much. Some studies are saying about less than 50% of reported cases in AMR. And there's a projection that by 2050, maybe 50 million people die of AMR. Before it's been 10 million. The costs, and if Africa is not doesn't have data to support, it means that possibly the evaluation or the prediction is an underestimation. So it means it's going to be a bigger problem than it is. In Ghana, it's becoming popular for AMR. So we're hotspots for WHO. So it means that we're popular with the cocoa and corruption and then AMR, which is not very good. We have to change some of them and fix some. Now the global response, as early as 98, the World Health Assembly came with a resolution, the idea to contain AMR. 2021, and the strategy framework was designed to contain AMR. We'll talk about the objectives. But now the focus comes to us as recent as 2017, where we designed the action plan. We'll talk about it in the subsequent slide. So the containment, reduce the burden and spread of infections, improve access to appropriate antimicrobials, improve the use of antimicrobials, the core stewardship, strengthen the health systems in their several capacities, enforce regulations, and encourage development. So I think before I start, I should mention that we agree that the AMR problem is in this hospital. But I want to fix what we can, what we have control over. I don't know which of us here has control over regulation to make some of these things, but at facility level, what you want to do is what we want to focus on. So key groups were focused on the strategies. The patients want to educate the patients, want to discourage self-medication, to ask them to access healthcare facilities. I don't know, be at home and say, because when I went, I was given this antibiotic for this reason. I didn't complete it, and then Dr. Awosu, my brother, has a similar, and I want to share with them. I think all of us agree that they are not things that we should encourage. With healthcare professionals, want to do the education, want to encourage guideline appropriation and prescribing, also in our use, and provide feedbacks and all in there with regards to AMS. At the facility level, they are looking at the WASH programs we have, IPC. Because the idea is to cut the infection. If we agree that the use is a main driver of an AMR, then the best thing we can do is to avoid the use and avoid the determinants. Because if you do not get the infection, you don't have to use the medication. So all the IBC programs that are offered, I mean, the focus was there. And there's government, that's a policy level, you know, that's policy level for AMS. Now the action plan, I'm sure all of us have seen that before. This is the old action plan, 2017 about 2022. There's an updated one we'll talk about going forward. The old one, May 2015, the members were encouraged to go and create or design their action plans based on this one with the 5 objectives. Awareness creation is what I'm doing here right now. That's the first objective. So I think, fortunately, because you are in AMS, within AMS you learn education, you're going to remind all of us that there's an AMR problem. You'll see that we know who will vote for the next election, but they'll remind us to make billboards everywhere and posters. Just to show us that they are there so that we don't forget them. You know, attention is important, so we want to use that to do some of these things. All of us use MTN or Telecel or Dtc, but they'll remind us that we do very big billboards. I think going forward, we should consider having AMR billboards at certain parts of that, you know. I mean, to help the awareness creation. Strengthen surveillance, reduce infection, that's IPC. Optimize the use and then make a case for funding and sustainability, because it's not, we're hoping that this won't be a one-off thing, but then it will continue. And also, with you already in AMS, I mean, you appreciate what it is to sustain the project over time. I don't know how you contribute AMS members, whether there's a funding, all those things. So there's also the plan to be able to explore those areas. Now, Ghana designed an action plan based on the global action plan. Similar objectives. So wherever the focus is, and all the documents are free and available to look at. Now, this year it was updated. Now it's a 10-year plan. There's a new global action plan for them, and also the members are also. So people are doing a lot of work on assessing the implementation and all those things. So the second one has a few changes. Now there's a one health approach, I mean, as part of it, because we can't be in isolation. We can't fix AMR at hospital and not know what is happening with animal and farm and the environment. So then, right now, other agencies are involved, Food and Drink, UN environmental programs, and the World Organization for Animal Health are part of it. The aim is to preserve the ability to treat human, animal, and plant diseases by equitable access. So they are all involved right now. And the target by 2030 is that we're hoping globally to reduce air mass deaths by 10%, reduce use and agric, and then minimize pollution of these microbes. And what happened yesterday, I mean, when we think about it, it's very to predict that we should be having problems with infection very, very, very soon. There was a town that their community, I'm looking away for toilets, I've said this already, so why should I find the word again? And it was being carried in a flood. That's a big problem, because we don't know how far those things happen. Even yesterday, so many problems. Our woman was flooded. Now there are concerns about whether we could pick up problems from the flood from I don't know where the water will terminate, whether it's by your house or by my house. But that's the problem that we should see. So that's the environmental bit that's becoming evident to us. So right now there are 6 objectives instead of 5. There are 6. The first one is the same, awareness creation. The second one also surveillance systems, laboratory diagnostic stewardship. You cannot have a proper AMS project or program without microbiology, because if we're saying that we want to encourage targeted treatments, it means that we want to see a culture being done. We want to make our decision points based on the cultures. So microbiology is very important. So lab capacity. IPC remains inside them. And to ensure equitable access and appropriate use of it, and safe disposal of antimicrobials. I've seen the FDA doing some work about disposal, and there's so much concerns at facility level whether the people do not come and supervise the incineration well enough, how much they are paying to do this, all those things are all captured in some of these ones. Accelerate research, because it helps. If we're going to make policies, it should be based on evidence-based data. Now the addition is the strengthened multi-sectoral governance, sustainable finance, and accountability for coordinated MR response. So there's a governance architecture included in this action plan that was not comprehensively discussed in the previous one. This is the document, just to show you, it's accessible to all of us on the WHO website. You can be able to have access to this. Our key takeaways, I mentioned that it's a natural process, accelerated by use. Use being it rational or irrational. When we look at, you spoke about the RUM and how AMS had impacted your antibiotic use. So if you, when you look at it, what I realized is I'm not pointing fingers at any specialty, but to compare adult and pediatric use, there's high antibiotic use in pediatrics as compared to, it's a similar thing you expect at the community. And again, I'm not accusing the mothers, but I mean, very quickly, we the mothers are in a hurry to solve the problem with antibiotics. I'm sure it's relatable. They're not smiling at me, they're not very happy with me. But I mean, so that we get a fair idea of what the picture is. Now the burden is historic. I mean, the number of deaths, I think 1.149 million people died in 2022 or so. And the numbers keep going up. We shouldn't be dying from AMR associated infections. And the response has matured over time. Unfortunately, there are gaps in the response. I'm really talking about the global action plan because in the last meeting, we discussed that about 10% you don't have funding for the project. So you see, we can design the framework, and if we don't have resources to now implement the framework, it becomes obsolete. It is there, but we cannot use it because certain logistics have not been achieved. So the ability on that measurable targets and clear evidence. We should all take a look at it. It should be straightforward and to see what you want to do in your particular space. This is the end of this presentation. Thank you. I'm sure you don't have any questions. It's kind of general. I mean, are there any questions before the next one? So if you have any questions after I leave, you can go to pharmacy because I'm one of them. So they will answer the questions for you. So the next one we'll do quickly. Is to look at some drivers of AMR. I spoke about use. So we'll look at some. So why it matters, I think I've made some of these ones already. Oh, what we cover? About why we're trying to do this, to avoid the debts and all with respect to it. That's how much money is projected to be lost in trying to support these programs, over $1 trillion. So the drivers, inappropriate use, I spoke about it being, so there's overuse and underuse. Using for too long, using for too short a period. There's some analogy I used to, another thing I say, if you come out from this door every day at 8 a.m. and I slap you, how long would you keep doing that? I'd be surprised if you came the third time. I'd be very surprised because I assume that you will use a different method to come in. Or you come with a gun, because clearly, when it comes to fisticuffs, I don't think I have much in the room. I mean, I'm a very intimidating person. When you're tall and like that, I mean, when it comes to you intimidate other people. So then the whole other thing is that if the incomplete treatment, for instance, if you will go to war, right? A classical example is when America lost one of their bombers to Iran. I don't know if you remember, one of their fighters was hit. And how much money and how much resource that the Americans used to save the pilots one and destroy the aircraft. Because they couldn't use it. The idea is that when you leave the house for your enemies, they learn the strategies. So if you leave some of the antibiotics for the microbes, then they're able to learn it. So you want to have complete eradication. That's where the low use comes from. So if you feel better, then you don't continue, then it becomes a problem. We see it in so many of treatment. There's a salmonella treatment, for instance, 10 or 14 days. This is wrong. It doesn't mean that before 5 days you don't feel better, but you want to achieve complete eradication. There's other conversations about the H. pylori eradication, 10-day, 14-day treatment. And it's showing that the 14-day it might be difficult to take, might be expensive to acquire, but then that's the price you get to pay to fight some of these problems. Weak IPC. We had a very nice conversation at Greater Accra Regional Hospital recently, where apparently in some studies, people who were in offices had a higher chance, were at higher risk of infection as compared to people who were on the field, like with the patients in the wards. There was another study that compared microbial load from the water closet. I don't say toilet bowl, but I don't say, you know what I mean. So they swap from the bowl, then they compare to when they swap against the computers. And funny enough, our keyboards have more microbial load than those. You see, also because we clean those places. The nurse on the ward will wash their hands regularly because they've seen the issue over the other offices. So if the people who are usually non-clinical staff are assuming that, oh, we're not involved, I'm in my office, when we leave the wards, we come to your office. And also because you don't see the problem as much, so you're not in a hurry to wash your hands. Because we see, the nurse is trying to drain abscess, so they appreciate the whole condition. They know that, oh, it can be dirty there. But in the admin office, there's finance, there's security, you don't expect, even when the cleaners are cleaning the facility. I've seen one where she held the door handle with her gloves on. That same gloves will hold them up, will pick the bin bags. So you see, when you come to your office and you open the door, you don't assume that it wasn't because we train them to be able to listen, to work quite aseptically. But they are holding our door knobs with it. So you assume that, oh, head of or director of the facility, if I didn't go to the ward that day, someone who was coming to pick your pen could have used their gloves to hold your, that is where IPC comes in. So the wash programs, the hand hygiene programs and all that, the PPE use and all, is important in these in AMS. The environmental discharge spoke about disposal of antibiotics. We don't know how they do it at their houses. We don't know whether they pour leftover antibiotics through their sinks. That becomes a problem because then they're exposed to the environment. Then the spillover, I spoke about trade and all. That's difficult to control, but please want to focus on going forward. Another issue is the substandard of falsified medications. Back in pharmacy school, some people's projects would have been to sample certain medications on the market and then assay them. So maybe they'll pick Marina, amoxicillin, Kofi amoxicillin, Asima amoxicillin. Then you come and assay them. So if it says 500 milligrams of amoxicillin, how much is inside there? And then you get final results. With some 200 milligrams, the rest is chalk or some powder whatsoever. There's a study that says that about 1 in 10 medications in Southeast Asia and Africa are fake. That's a very big problem. And if you are going to use fakes, you are going to have things like underdosing. So substandard is where, it's not optimal, right? Those ones are also approved medications. But you see, we do these things in batches. It's like pharmacovigilance. You want to check in batches. So if, for instance, Marina Pharmaceuticals has had approval for one medicine, doesn't mean that from approval date till 10 years after it's going to be the same, right? So they can have some of those challenges. Falsified now comes in where certain people will make fake, that is malicious. Negligence can make you have substandard, but then with intent. So you pour water into this one and put a label on it as sanitizer, and you use it without ever knowing, and it doesn't work. So, like I said, identification is where we can do at this level. But right now, you see, with the flux of medications across our borders, we cannot control some of these ones. Some of the counterfeits can be so good you can't even tell the differences. There's been so many methods to help identify. There's a QR code system, there's a barcode system, but one thing that helps is when you procure from trusted sources. Usually when I know who can get it for me cheaper, is there, you come to a problem. Because when you go to I know who has it cheaper, yeah, you get some of these falsified medications. You might buy from, but fortunately in a facility like this, I mean, even with the problem with the framework contracts, we still get essentially from medical stores. And then would assume or expect that due diligence was done by those people. FDA had checked all those documents to make sure it's right. In one of our, in a conversation recently, one was asking how sure we are about the as hospital level. And I asked that, when you are going to fly, or when you are going to Kumasi, you don't go and look at doctors, the driver or the pilot and ask for their qualifications. You pray to God. And I mean, it's as much you can do as the facility. When medical stores brings it, I mean, you are hoping that, so I told people that, I showed the medication on the I said, once for myself, it is safe for use. That's a blanket statement because I hope in the system that those things would have been done. Because I can't get up and I don't think you have the capacity to be assaying medications. So you only hope that whatever they're giving you from there is good enough. I've spoken about overuse of, and there's access also. I mean, we're hoping that you're prescribing. That's why the REM survey is asking for generic prescription from EMLs, where it's accessible. Because if you write and we can't find it, the work is not done. Every patient can be able to have. Those factors go into redesigning guidelines, STGs, so that we'll be seeing some medications in our guidelines when our patients will not be able to access it. Then there's a behavior change, and the difficult part, because most people are used to a system. Because over remember in the beginning, some of the conversations in some facilities, they're like, oh, we've used this for so long and it's working. I remember when we started enforcing chloroxidine gel for surgical site infection. Then people said, okay, to the prepared spirits. I mean, there's those things, but it takes some time for those things to happen. And I think even at the AMS committee level, when you make an intervention and you want to make a policy, there's always a kickback. When we're introducing AMR ward rounds, some didn't understand why we're doing separate AMR ward rounds. Because when we find issues, we call on the specialist or the doctor involved. They didn't think, some people think AMS is policing them. I mean, there's all those things. But once the social area is expected, it is. And usually, inadequate prescriber knowledge is key. The Bible says, for lack of knowledge, people will perish. So you make a mistake in your prescribing if you don't know, you are not abreast with it. You are still using 1984 guideline or something when things have changed. Because the mindful are older now and they know better. Patient expectations, sometimes they expect this from us. But when I went there, they gave me this. Why do you not want to give me this? There's an example when Lekman Hospital started delayed prescribing, backup prescribing. You see, someone who had come there, they didn't understand the project, went to a different facility and said, so the news came later that, oh, Lekman will not prescribe antibiotics, which is flawed. It's clear misconstruction or miscommunication or misunderstanding from the whole project. But that happened because the patient expected that they were given antibiotics. But the project was saying that if the doctor felt it could be viral, they write a post-dated prescription. So if today is 30 June, doctor can write July 2 on that. The idea is that if you go and you feel worse, and then you come back for the antibiotics. And because of that lacking, whatever, then that happened because the patient had expectations. So I won't be surprised patients will go and pressure prescribers to write for them antibiotics. So that can be, and that's one of the gaps that we have. Then economic incentives. Fortunately, I don't think for here, but we've had conversations and more in private places where it is part. I mean, there were those times when at the pharmacy, the moment you start seeing one particular medication, and you know the rep has been around. I don't do the same thing here. You see that this Tuesday morning, they are writing Mawena amoxicillin. You can know that the rep is somewhere telling them to prescribe whatsoever. So then, whether there's a incentivized, whether it's not for me to speak or it's not for us to speak unless we have it. But then that can affect our prescribing patterns or habits. IBC, I've spoken about it extensively. Then low immunization now part of the world. I mean, Africa and in other places they are big on immunization. People take flu shots. In Ghana, we do the day and move on. I mean, that's. But then if we encourage it, because these things will slow down infections. If you are better vaccinated, then the chance of you getting an infection will be minimal. We've spoken about the environmental element cross-border. And so a great spillover, trade, manufacturing, products, and so on. Also, we've spoken about substandard and phosphate medications, where there's regulation. I mean, recently there's been a problem about the tramadol or topentadol, whichever one, the sildenafil 200 milligrams and all those ones. They get over here somehow, but they're not even manufactured there potentially. So where they are passing, you and I may not know, but they go through someone's borders, I mean our borders to get here. There's something regulation should focus on and try to. But if they bring us the best, we sell the clients the best. But if the worst is mixed with the best, it's difficult sometimes to control some of them, these ones. So as part of stewardship, there's a focus on that area. I spoke about hospitals being one of the big, or there is a quest for airborne infections, and this is sometimes to show. I mean, everybody comes here. When they are, someone said, was the mecca of free violence and the guy. I don't know how the Muslims feel about it, but I didn't say it was. Someone said it in 1959. But that's the point. It's where all the microbes, I think they have EGM here, but I'm surprised that all of them come here periodically. Everybody who is sick comes here, they come here. Also community. That's why a lot of us health professionals went down during COVID. At the facility that time, we lost a few people. Certainly, they were exposed. I mean, we can't see that at the hospital. And then there's a high chance that they were, especially those who were in the front line, who were handling some of these cases. So then it means that you and I here at the hospital have a lot of friends who are Americans. As compared to those who are in community, there more reason we should take it a little more personal. Now, surveillance, in the subsequent slides, we'll talk about that. I won't speak about it too much. But in the earlier presentation, if you are not monitoring, it's difficult to make progress. And because you have done the TBPS, I mean, for instance, you see how it is, you can compare your baseline to your next BPS. I remember in the very first BPS, it was a very terrible baseline. Finally, you assume that we're doing what is right. You know, at prescriber level, we're doing what is right at pharmacy level, or even at the nursing level. You see, because something like delayed administration, for instance, is a problem with AMR. Our community, you see a prescription for an antibiotic. If today, June 30, it was written 14 June, meaning secreting half an hour, but that is delayed administration. The microbes might have changed, the condition might have worsened, and they were not coming to get medications for that might not work and feed into the AMR problem. So when you do the surveillance, it helps. I mean, when you do audits and all those things. But this will focus on lab surveillance also, because you cannot inform your treatment guidelines without their data. I don't know that you have an antibiogram at the facility, to my general, that you used to feed your specific area. But I'm sure in the subsequent presentations, we would appreciate some of these ones. We spoke about the action plan and what it looked like, so I'll just skip that. And then how we want to address the drivers. So I want to speak to our objective here with JHS about the improving capacity of Dtc to address the AMR problem by setting up the committees and possibly designing specific guidelines. Because we agree that the more specific they are, the better they are. Because we can use a blanket one, like for all of Ghana, but the dynamics in our sensitivity and resistance are different. For Lepo Hospital, for Tama General, for Eastern Regional Hospital, I mean, that's picture. So we want to have one that is specific to you based on your surveillance data. That is a diagnostic stewardship. So there's that. That's why we also focus on multidisciplinary AMS consult or projects. So everybody has something to offer in the AMS programs. Governance. When we go into the core elements of AMS going forward, I think we would appreciate what it means, because you make interventions at AMS, you form DTC. It has to become instruments. So that if I come from Marina Hospital and I'm now with my general, I don't see it because as that facility, that's what we do, so I'm comfortable with that again. Your decision from AMS will be backed by leadership. Once I'm committed to be able to help you force through the barriers, because behavior will change at certain areas. At one facility, what we did eventually is that they don't prescribe, they don't dispense more than 24 hours of injectable antibiotics. I mean, all the IV antibiotics and all. If you write for 10 days, they supply for 24 hours. That also pushes for you to review the patients. So I can review, so I don't be a blanket. So when you write for 5 days, they supply, and then because we want to encourage, because the things will change, especially if you have requested cultures. When they come, we want you to inform that decision. The prescriber consent, oh, the relatives are here, they can pay now, when they go, they may not. There are all those challenges. The beauty about it is that you set it up in a way that works for your facility. There's no strict, everybody does. And I'm sure you're doing very good work already. I mean, I've heard a lot of things, but we're testing to create awareness even better. So the use is central driver. I spoke in the first slide. And then with behavior change, we require awareness. So we're hoping that some of these things will be taken up. I don't know how often the AMR workshops are done here, but then we would encourage that they're done as soon as possible. Other people employ their clinical meetings, so they don't get to allocate a lot of funding resources to some of these workshops. Prevention is key. IPC is always going to be the first cousin of AMS. We couldn't do that without IPC and hygiene, amongst other things. Then the governance and financing will sustain the project essentially. We couldn't also do without them. Thank you very much for your attention. If there are questions, I'll take it. Otherwise, Dr. Chandler will take the questions.
I think I'm sure it's better for him. He's so nice. So the floor is open for questions, contributions, but before then we'll do a little introduction from here.
My name is Dr. Josephine Bani from Ghana Health Service Clinical Laboratory, IC.
And welcome. Please, do we have questions? You know yourself, you know your heart. Do you have a question or you don't have a question? Contribution. The way the weather is, we need to stretch a bit. So if you have questions, let's know so that we address the questions. If no questions, say no. Questions? No questions, contributions?
Conference or conference?
This forum says no question. No question. Contribution, no question. No question. Okay. So we'll stretch a little bit. for just a few minutes. We'll come back and then look at module 5. We'll take something from the laboratory. Then we'll call it a day. So let's stretch for just about 10 minutes and then we convene again for the listening part.
No, let me introduce you to in his name. Who goes for chapel to you?
The right answer is your language. So I got to change it. The right answer you see the last one, I guess it's Monday. You see that you will be resolving. It's on the class. I put it on the class. So you can get
So I'll go more than that. Yes, for Anti-Joyce.
So yes, chill.
All right.
You have started when? But where are you? I walk around the hospital and the face. So you are not here, you are here. The way the system works, everything else.